Good. So today's class is the last of the theory sessions. And as I mentioned before, the idea is now, instead of going from the imaging modality, as we have done before, so we try to explain the different imaging modalities and then see what kind of data that they give. Now I would like to start from an application. So say like, look, we want to do, in this case, cardiac imaging, because as I said, my research field is in cardiac imaging, so that's why it's easy to use that as an application. But independent of that, so looking at it from the point of view of the modality and or from the point of view of the application is in a way different. So it's looking at the same way, but actually it will help you in trying to understand what information we can get from the different modalities and how we then can choose the modality that is most relevant, or how we can compare these and integrate them. So okay. So in principle, I think you all know, but let me quickly repeat. So when we do cardiac imaging, we try to visualize and quantify the cardiovascular system. And so as you know, the heart in most of us is at the left side within the chest, so within the thorax, behind the ribs. As I said before, the fact that it's behind the ribs has relevance, especially for ultrasound imaging. And it's in principle a little bit pointing to the left also, downwards. That's what we say is like the point of the heart, which is called the apex, is there. That's connected to the whole circulation. And when we look at the inside of the heart, so the heart has 4 chambers. So it has a left chamber and a left atrium, which is connecting to the systemic circulation through the aorta, so which is the largest artery in our body, and provides thus the blood towards the peripheral organs, so provides oxygenated blood through the organs. And then afterwards, the blood is actually returning back. So when it went to the periphery, it's returning back to the heart, but it's now returning through the right atrium and the right ventricle, after which is being pumped into the lungs for oxygenation, and then comes again into the left atrium in order to be pumped further. So we have these 4 chambers, and these 4 chambers are relevant. It's quite relevant that it became 4 chambers, because that optimizes the cardiac function, as we will see later on. And it's also in such a way that we have 2 circulations which are in series. So that's actually like 2 different pumps, but they are, in normal cases, of course, there's abnormalities where it's not so, but in normal cases, they are connected in series, and they work together in order to pump the blood around the body and to pump it through the lungs to have it oxygenated. Now, when we look at the structure, the detailed morphology of the heart, so let's first look at this part. So if we would take a cross-section of the heart, what you will see is that the left side, so the left ventricle, the left chamber, is actually circular in cross-section and has quite a thick wall. While when we look at the right chamber, what you see is that actually it has a much thinner wall and is actually like attached to this left ventricle and is more like crescent shape. So the reason why we see these differences, for example, in the thickness of the wall, is obviously because in order to pump around the blood through the whole body, that needs a much higher pressure than pumping the blood around through the lungs. And the lungs is a much shorter circulation, and it's actually also a much lower resistance and also more compliant system than the peripheral circulation. And keep in mind that obviously the volume being pumped through both ventricles has to be the same, because they're connected in series. So that means that the volume ejection is the same, but it needs to be ejected at much higher pressure at the left side compared to the right side. And that makes that, obviously, first of all, the cross-section of the left side is spherical, because the sphere, according to the law of Laplace, would be the best shape in order to have the lowest stress in the wall for a certain pressure inside. So that's why that's spherical. It's also thick, because the thicker the wall, again, that is to reduce the overall wall stress by the pressure. Now, the fact that the right side is like attached to this in this way and not circular also in itself, which actually would be a little bit more efficient, is that actually the whole heart also has to be efficient. And so it makes that actually the outside border of the heart is again more or less a sphere roughly in diameter. And one of the things that you will also see is that actually the whole heart, the way it is kind of within a chest, the whole heart during cardiac contraction is not changing in size. Because if the whole heart would also contract, so if the outer contour of the heart would contract, that would mean that the lungs have to deform and that you would get a vacuum around the lungs, which would be energetically extremely inefficient. So the heart is made in such a way that it can contract so that it can eject blood from the inside, while the outside border is actually not changing. One of the things that is relevant there also is that actually the whole heart in your chest is embedded in a sac, which is called a pericardium. And that's actually a rigid sac. It makes that the heart cannot expand, but the heart is not connected to the sac. The heart can actually freely move within this sac. And we'll see that later on. So that's with regarding to the shape of the different ventricles. And then the other thing is also what we want is we want the circulation going with a flow only in one direction. So to keep this unidirectional flow, what we need is we need valves in between. So what you will have is you have each time in each of the sides of the heart, you have two valves. One valve, which is between the atria and the ventricle. In case of the left ventricle, this is called the mitral valve. So that's the valve that separates the atrium from the ventricle and makes that the flow can only go from the atrium to the ventricle. And then there's a valve between the ventricle and the artery, the large artery, so in this case, the aorta. And so that's the aortic valve, and that makes that the flow can only go into the aorta and cannot go back. So this valve system that we have at both sides is important and will be something that, of course, can cause some problems. So you will see that there's valvular diseases that need to be treated, and we need to detect these also. One of the things that you also see is actually that the morphology of these valves is very, very different, because this valve, the mitral valve, has to be closed while the pressure is high within the ventricle, while the aortic valve has to be open while the pressure is high and has to be closed when the pressure is low. And so that means that actually they evolved in very, very different kind of structures, including, for example, here, what you see in this mitral valve, what you see is you have the valve leaflets, but then you have these kind of strands, which is like cords. So this is kind of like called the tendinous cords of the heart, or the heart strings, as some people say. What this actually does is this connects the side of the valve to the muscle, actually through kind of muscles that we actually call the papillary muscles. But the idea is that when the valve is closed, these cords will kind of prevent that the valve would kind of prolapse, that the valve would be pushed by the high pressure into the left atrium. So this is really kind of holding back the valve leaflets and then provides extra mechanical support to keep it closed and not leaking during the ejection when the pressure is high. The other thing that you see is that obviously we need, since it's muscle, and muscles in our body can contract after electrical stimulation. So we need somehow an electrical activation of the heart, and we also need to have this being periodical. So because we have this continuous kind of contraction, pulsatile contraction of the heart. So the heart has to beat, and also the frequency of this heartbeat has to be modulated with the volume of blood that you need in your body. So when you do exercise, for example, what you see is that you will need much more volume. So you need a faster heartbeat, and so that needs to be controlled. And what we will see is that actually the control of the heart rate and of the electrical activation is actually located in what we call the sinus node, and that's a bunch of cells which are located at the top of the right atrium, and these cells actually spontaneously act as an oscillator. So these cells can kind of depolarize, repolarize kind of automatically, and their rate is actually determined by innervation. So we have autonomous innervation that is actually determining the rate. From then, so these electrical pulses that are actually starting in the sinus node, they actually first arrive in the atria. So through kind of conduction fibers, it arrives in the atria, and then they initiate the atrial contraction. Now, one of the things is that in order to have a proper flow through the heart, that means that, of course, the atrium and the ventricle cannot contract at the same time, because the atrium, its task is to push blood into the ventricle in order to prepare it for the next ejection. And then when the ventricle ejects, obviously the blood should not go back to the atrium. So that means that while the atrium contracts, the pressure in the ventricle still has to be low. And then when the ventricle contracts, obviously when this valve is closed, the atrium should not contract. So because of this, what we have is that actually within the heart, the connection of the atria and the ventricles is actually purely fibrous. So that means that actually that's an electrical insulator. So there's no electricity that can pass from the atria to the ventricle. So the whole surrounding where they're both connected is fibrous tissue and is not muscular tissue, because muscular tissue would actually propagate electricity. So what we will see is that this is totally electrically insulated. So that means that the atria can contract and then fill the ventricle. Now, when the atria are relaxing, so now next the ventricle has to contract. And so the electrical stimulation of the ventricle is actually done through another node, which is what we call the atrioventricular node. And what you will see then is that this is a bunch of cells that act as like a signal delay line. So what happens is the electricity arrives in this bunch of cells, and then only a little bit later, actually the cells will propagate electricity to the only electrical connection that there is between the atria and the ventricle, and that's called the His bundle. So that's like a special bundle, which is really kind of sheet of collagen with cells inside that are fastly conducting. And then this immediately splits in a left bundle and in a right bundle, which then splits in very, very small kind of electrical wires, actually, that connect to the inside of the heart, which what we call the endocardium. So the inner wall of the heart, or the inner surface of the heart, is called the endocardium. And so there we have this Purkinje system that then attaches to cells and then would do the electrical activation. And this makes then that the ventricle will contract after the atrium, and so you get a kind of proper functioning. Now, another thing that you also see is when you look at this ventricle, what you see is that the outside of the heart is actually very smooth, but the inside of the ventricles is actually very spongy. And that's what we call trabeculated. And one of the things that you see here, this is the inside of a left ventricle, this is the inside of a right ventricle. You see actually that the right ventricle is actually much more trabeculated than the left ventricle. And you can actually prove that the sponginess actually is advantageous in order to eject volume. It's very good to eject volume, but it's not great to develop pressure. So you have a kind of a balance between the amount of trabeculations, which help for volume, not great for pressure. So that means that you can have much more trabeculation in the right ventricle, which works at lower pressures than in the left ventricle. We're not going to go in detail there, but this is something which is like one is relevant in a real anatomical specimen. One of the things that we will see is that actually currently the resolution of the clinical imaging technology is not good enough to really study this in detail in the individual, which is a disadvantage, because it is functionally actually quite relevant. One of the things you also see is that actually on top of these trabeculations, and you see here once in a while also these kind of little kind of wires, more or less. So actually the activation system, so the Purkinje system, these electrical wires are actually on there. Now, one of the things that you also see, and you actually see it already here when you look at the outside, is that actually when you start looking at the functioning of the heart, so the heart is built of cardiac muscle cells, so cardiomyocytes, as we call them. And cardiac muscle cells are relatively big cells within the body, and they actually are very elongated. And so when they're electrically stimulated, they can actually contract and develop force in the direction of their longest axis. But when you look at muscle cells can contract with about 10%, maximally 15%. So it's very little that they actually can deform. And when we look at the heart, what we see is that the overall heart, with every heartbeat, is able to eject 60% of its volume. That's what we call the ejection fraction. So in order to be able to eject 60% of the inner volume with only 10% of cell deformation, what we will see is that evolution has made that we have a very peculiar and very specific arrangement of these cells within the muscle wall. And what you see there is that actually the muscle cells, first of all, the muscle cells are more or less arranged in fibers. It's not really fiber, but they actually more or less align towards each other. And of course, they are connected, individually connected. And what you see is that actually at the outer part of the heart, which is what we call the epicardium, what you see is that these cells are arranged roughly from the valve plane towards the point of the heart, towards the apex, but obliquely also. So you see that they're arranged there. But the more you go from the outside of the muscle towards the inside of the muscle, what you will see is that there's actually a gradual change of this direction, so that you see that actually in the middle of the wall, what you see is that the fibers are not anymore from the valve towards the apex, but the fibers are really going around the circumference of the ventricle. So you really see that they're here like totally circumferential, as we say. And if you then go more towards the endocardium, so the inner surface, what you will see is that again, they become a little bit more longitudinal. So you have this very gradual, continuous change of the angle in which the cells are oriented within the muscle wall that changes from what we say longitudinal in the outside towards very circumferential in the mid, and then again longitudinal in the inside. And here you see some kind of histology analysis of this, where you clearly see that this direction is gradually changing from the outside towards the inside of the wall. And this is very relevant for the mechanics. We're not going to go very much in detail, but also if you continue with, for example, if you're interested in modeling of the heart or trying to make computational models, these are things which are extremely important in order to understand how the heart is functioning. Now, if we then look from this kind of morphological way and the electrical activation, if we then look towards how the heart is then functioning or how things are changing throughout the cardiac cycle, then you have a couple of things which are important. So first of all, you have the ECG. And when you do cardiac imaging, you will always need an ECG because that will determine where you are in the cardiac cycle. And also, as I told you before, if you have relatively slow imaging modalities, you might need the ECG in order to combine information from different beats in order to then reconstruct a full volume of the heart. Now, the ECG, as I said before, physiologically, the activation starts with the activation from the sinus node, and that is actually on your ECG shown as the P wave, as we say. So this little P wave is actually the physiological onset of a cardiac cycle. So the P wave shows you the electrical activation of the atria, and then you have a little break, and then the activation of the ventricle is starting. So after it goes through the AV node, and that is the typical, what we say, the QRS complex. So the typical kind of point, the spike that you always see on the ECG, that actually represents the time in which the electricity is actually spreading on the ventricle. Then there is some time that there's no electrical activity, but there's mechanical activity. So that's when the heart is ejecting the blood. And then you see that the cells are actually repolarizing, and that's called the T wave. So these are the parts of the cardiac cycle. And so they determine the onset of ventricular contraction, the time period of the ejection, then the start of the relaxation, where then the blood goes back into the ventricle in order to prepare for the next heartbeat, and then finally the atrial contraction, which again helps in filling the blood. Now, when we look at this with regard to, for example, the pressures, what you will see is that, of course, at the onset of the contraction, so when the ventricle is contracting, so although, as I said, physiologically, the cardiac cycle starts with the onset of the atrial contraction, we mostly look at it when we look at cardiac function, we mostly start from the onset of ventricular contraction. So we start here, onset of ventricular contraction, electrical activation of the muscle, the pressure within the ventricle, in this case the left ventricle, is increasing up to the point that the pressure in the ventricle becomes higher than the pressure that is currently in the aorta. And what happens now is then, of course, the aortic valve can open. And once the aortic valve opens, what we see is still the pressure rises a little bit in the beginning, but actually the volume is starting to decrease. So this is the volume of the ventricle. So what you see then is that the volume will start to decrease while you have the ejection, of course. Then at the moment that the contraction is over, what you will see is that then the pressure in the left ventricle starts to drop. What you will see then is if the pressure then drops below the pressure in the aorta, the valve closes again. And then what you will see is that the mitral valve will open at the moment that the pressure in the ventricle becomes lower than the pressure in the atrium. Then this valve opens, and then you start to see that there's flow coming into the ventricle, and then we start to get the filling. And then with atrial contraction, we again get more blood into the ventricle. Now, of course, one thing is that we can look at the physiology and the anatomy of the normal heart, but of course, when we look at clinical medicine, we're mostly interested in what abnormalities is going to happen in the heart. So which are the types of abnormalities that we need to be able to image and quantify in order to be able to treat and diagnose our patients. So the most common in cardiology, so which is really the big bunch, probably 90%, if not more, of the cardiology patients are actually having trouble with their coronary arteries. The coronary arteries are the blood vessels that actually bring the blood to the heart itself. So because of the pumping, so for the contraction of the heart, of course, you need a lot of energy, you need a lot of oxygen and a lot of nutrition. So that means that there has to be blood to the heart itself, and that's actually provided by what we call the coronary arteries. And we actually have two coronary arteries that are originating from the aorta, actually right above the aortic valve. We have two coronary arteries coming, a left and a right, and the left is actually splitting immediately in two. So clinically, we have three coronary arteries that come from two origins in the aorta, and they provide the blood to the heart muscle itself. Keep in mind that about 10% of the blood coming out of the heart, so 10% of the ejection of the stroke volume of the heart goes back to the heart. So the heart uses about 10% of the blood in order to function. So it's quite a lot for being a single organ, but obviously it needs a lot of energy in order to provide the pressures and the deformation. Now, the coronary arteries, they're actually the big arteries themselves, they're at the outside of the heart. And so they're what we call at the epicardium. And then from there on, what happens is that they start to split, they divide over the whole surface of the outside of the heart, and then they will actually enter the tissue, and then will make sure that they can provide all the parts of the heart muscle with blood. Now, the problem with these coronary arteries is that we can get coronary artery disease or atherosclerosis. And what happens there is that within the wall of the coronary artery, we get actually an accumulation of predominantly lipids to start with. So for example, cholesterol and other lipids are actually accumulating here. And what you will see there is that because of this, what starts to happen is that the diameter of the vessel is starting to decrease more and more, because of the abnormality within this vessel. And that's what we call a coronary artery stenosis. Now, one thing is that it becomes narrower and narrower, so that is potentially a problem. One of the things that you also have to keep in mind is when you look at the arteries, arteries are actually also dynamic organs, because arteries, they have to be able to change their size depending on the flow that is needed. For example, when you do exercise, whether you're Netflixing on a sofa, you will need approximately 5 times as much blood going through your system. because of the blood needed for the muscles and for the heart when you do exercise. So there is about a factor of 5 in what we say is in flow reserve. And so the coronaries need to be able to change the blood going to the heart itself by the factor of 5. And they actually do that by dilating. And so when you look at the structure of an artery, part of it is actually smooth muscle cells that can contract or relax and thus can modulate the diameter of an artery. So what you will see is that we need this coronary artery reserve in order to be able to do exercise. But if the coronary arteries start to be blocked more and more, what we will see is that as a reaction of a decrease in the diameter, actually the arteries are actually also spontaneously start to dilate. And so you very often have that patients with severe coronary artery disease, and so with a severe narrowing, when they're sitting on the sofa, they have no problems because the vessel is still large enough. But when they do exercise or want to do exercise, there is no reserve anymore. They cannot expand anymore. And that's when they start to get chest pain and they start to get symptoms. So they will be out of breath and start to get chest pain. So the fact that this closes is one problem because you can't do exercise anymore. But also the other problem, which is actually more severe, is that what can happen is actually that either it becomes so narrow that at some point you start to get kind of white blood cells or something accumulating there, or you can even get what's called plaque rupture. So that the thin endothelial layer, which is on top of this lipid, is actually rupturing, and all these lipids are released within the blood vessel, which immediately gives an enormous immune response and start to give clotting and things like that. And so that means that you can actually get a full occlusion of the coronary artery. Now, if you get an occlusion of this coronary artery, so that's called like a myocardial infarction, what happens then is that, of course, there's no blood going anymore towards the muscle. So say, for example, that here you would have an occlusion. That means that all the muscle, which is further away, which is what we call distal from this occlusion, will not receive any oxygen and nutrition anymore, and thus is, of course, at risk of dying because of this. And so that's a myocardial infarction. And if you do not reopen this very soon, within a couple of hours, what you then get is you get necrosis, and then you get like a full established myocardial infarction with dead tissue. Now, one thing is also which is relevant for the heart is the fact that when we look at these coronary arteries, what you will see is that actually pieces of tissue are actually exclusively perfused by one coronary artery in most human hearts, at least in normal hearts. So that means that this piece of tissue that gets the blood from this artery only gets the blood of this artery. And that means that if this artery blocks, you really start to get an infarction. This is not the case with many other organs in the body, and especially, for example, when you look at the brain, because the brain is, of course, when the brain vessels, you see the same problem. If you have coronary artery disease, you very likely also have problems, for example, in your carotid arteries or in the arteries within your brain. So the thing is, the fact that we do not have as many brain infarcts or strokes as we would have cardiac infarcts is by the fact that when we look at the brain circulation, what you see is that actually in the brain we have what is called a collateral or redundant system. Because for the brain, for example, we have 2 carotid arteries, and also in the back of our neck we have 2 vertebral arteries. So there's 4 arteries going to the brain, and these arteries are internally connected through the circle of Willis. So that means if one artery blocks, actually the blood towards the part of the brain that normally would receive blood from this artery can actually be taken over by another artery. In the heart, this mostly is not the case. It's very rarely that patients are able to give blood from another artery to this. So that's the reason why we have much more problems with coronary infarcts, so with coronary artery disease, than we actually have with strokes. One of the things that you see also is like when we look at which are the preferential places where we get this kind of atherosclerosis, then you see that that's actually at bifurcations, for example. So where arteries are bifurcating or where we have a change in the angle of the vessels, that's where we predominantly get it. So that means that this is a process which is very much guided also by local flow phenomena. So because we know that if we have a splitting of an artery, then of course we have the flow that also has to split, and we might have turbulences around there, or we might have changes or stagnation of blood in some areas. And so both high velocities and low velocities of blood locally by these local changes can induce these abnormalities and can actually make this coronary artery disease worse. Now, if we have a full infarct, so that means that the artery is blocked, and then later on, we are not able to reopen this very fastly, as I come back to in a minute, what we will see is that we get a full myocardial infarction. And so here you see a specimen. So what you see is that the thickness of the wall, this is the left ventricle, so this is part of the right ventricle. So normally the wall is equally thick everywhere, but what you see here is you have a big thinning of the wall, and it's actually also a little bit whiter when we look at the tissue. So here the muscle has been replaced by scar. And so we really get fibrosis and collagen, which replaces the muscle cells. And so we have like a thinning and actually also a stiffening of the wall. And so, of course, the larger this is, the more portion of the whole ventricular wall we lose, and the less we will be able to generate the proper ejection. So it's important to limit this, but it's also important when we have a patient that has this, we need to detect this, and we need to be able to map where this infarct is within the heart. So besides problems with this infarct and coronary artery disease, what we have also some general types of remodeling of the heart, of the ventricles. And this can be induced by heart failure, can be induced by, for example, genetic diseases, can be induced by a leaking valve, which makes that during every contraction, some of the volume doesn't go to the aorta, but goes back to the atrium, for example. So that's like a volume overload that we say. Or might be induced by an increase in pressure, either by a obstruction of the valve. If the aortic valve would obstruct, we need much, much higher pressure in order to get blood into it. Or what we also have, we have people with high blood pressure, as we say, people with hypertension, because of stiffening of the vessels or some kidney diseases or whatever, that would also make that the ventricle has to work at higher pressures. And then we start to get remodeling. And there's two specific types of remodeling, which are the most common. One is called hypertrophy. So that means that the wall is actually thickening, but it's actually thickening towards the inside. So at the same time as wall thickening, we also get a reduction in the size of the cavity inside. And the other extreme is dilatation, where the heart starts to grow and actually the wall becomes thinner. So being able to measure and image the thicknesses of the wall and the size and the shape of the ventricles is something which is relevant in order to be able to describe the remodeling that is going on with certain disease processes. And here, example of this hypertrophy. So you see this is a normal heart, as I said before, left ventricle and a thinner right ventricle. What you will see here is a heart which has an extremely thick wall and a very, very small cavity. And the reason for this is actually a very typical genetic abnormality, where you have a gene mutation that induces a change in the sarcomere molecules. So the actin and myosin, which is inside the muscle cells, which are actually doing the contraction. And the result is that we actually get, at a local level, we get fiber disarray. So as I said before, normally muscle cells are nicely oriented and are oriented in a certain fiber direction that is then changing throughout the wall. But if we have these genetic abnormalities, what we see is that actually the cells are starting to crisscross instead of nicely being oriented. And this makes then, of course, that if the cells are contracting, they're not working together anymore. And this is a very inefficient muscle. And in order to compensate for that, we get this very thickening of the muscle. And as a result, unfortunately, we also get a very small cavity. And if we have a very small cavity, of course, with every heartbeat, we can only eject a limited amount of blood. So first of all, this is an inefficient heart because the fact that the muscle is much thicker and very often much stiffer. intrinsically because it has fiber disarray and thus cannot deform as well. And then additionally, on top of that, we have a very small cavity where with every heartbeat, we can only fill and eject a very small amount of blood. So we need a very, very high heart rate in order to be able to generate enough volumes with these hearts. The other extreme, as I said before, is a very dilated heart. And here is a specimen of a heart which is what we call a non-compaction cardiomyopathy, which is also related often to sarcomere mutations and some other mutations. And what we get here is we get a very large heart and a very, very spongy heart. So this is much, much more spongy than normal. It's a very thin muscle, and you see here even some muscle is kind of replaced by fatty infiltrations. So this is a very inefficient heart that is not able to generate pressure anymore. And that will start to fail at some point. And people that have this kind of genetic mutations in this kind of extreme, what you will see is that the only thing that can be done in order to help them on the longer term is actually a heart transplant. So a lot of these will need, when they're 30 or 40 years old, they will actually need a heart transplant in order to be able to function normally anymore. So again, what I'm saying is like looking at the geometry, the local geometry, the local thicknesses, potentially the kind of hypertrabeculation. All of these things are relevant in order to kind of discriminate the different types of diseases and try to quantify these diseases. Okay, so that's roughly talking a little bit about what a heart looks like and some of the major diseases. We don't go in much detail now. We don't have time for that. But now it's the question is like, how can imaging help in order to see these patients, to study these patients in order to make a diagnosis or try to do therapy follow-up or to see, to get some risk assessment, for example. So then we go back to what I told you before. So what are imaging modalities? Well, imaging modalities are actually ways to, as I said before, measure a physical parameter, and a physical parameter that is very, very specific for each of the individual imaging modalities that we have. And we hope that this relates to the things that we want to study, namely looking at anatomical structures, looking potentially at metabolic processes, looking at functional performance, and at the same time, functional performance also includes looking at bloodstream and perfusion. So that's in general. So every time we have a problem, and somebody asks us like, okay, how can we use imaging in order to look at this kind of type of disease or look at these patients? The first thing that we have to ask ourselves is always, what specifically do we want to look at? So before you say it's like, oh, we can use ultrasound or we can use MRI, we need to know it's like, okay, what do we look for? What exactly do we want to study? And so as I've tried to show you by showing the anatomy and some of the disease processes in the heart, what is clearly important is that we have to be able to look at the geometry of the heart, the sizes, the thicknesses of the heart, and we need to look at tissue structure. Is this heart infarcted? Is there some fiber disarray and things like that? So this is one thing that we want to look at. Obviously, since the heart is a functional organ that has to contract and eject blood, trying to quantify this contraction and ejection is relevant. So being able to see or measure how this deformation and contraction is taking place, that's another thing we would like to look at. As I said before, when we look at functioning of the heart, what we say the hemodynamics of the heart, then it's relevant that how much volume is being pumped by the heart with every heartbeat and at which pressure is this being done. Because what we need is the heart in general is a volume pump. So the heart has to provide the right amount of volume to the body. And in order to generate this volume, it will have to generate a certain pressure. And this relation of pressure and volume is something that describes the working points and the functioning of the heart. And so we would like to have imaging modalities or ways to measure or visualize this. Now, as I said before, also, it's like, well, we need to get this unidirectional flow, and that's why we have valves. So looking at the valves and especially the functioning of the valves, are these valves closing well? Are they leaking? Are they closing enough and opening enough. So this is important because that can determine of this functioning. So we need modalities to look at the valves, the structure of the valves, and the flow, the blood flow through these valves. And last but not least, as I told you before, since coronary artery disease is in cardiology one of the main determinants of problems, we need to be able to measure these coronary arteries. We need to see is like what's their size, are they occluded, are their walls, for example, having some atherosclerotic processes. So these are the things that we want to see. So you see already that there's like a whole bunch of things that we want to look at. And from what I've been saying about the imaging modalities, I think it's clear already by now that not one modality can provide all this information at the same time and with the same temporal and spatial resolution. So we really have to see is like for which of the modalities are we using and when do we need or when will we use another imaging modalities in order to provide for certain patient some specific answers. Okay, so let's now look at each of these imaging modalities and what they can offer in order to address these problems. So as I said before, what is always important in order to be able to see is we need to go back to these working principles of these imaging modalities, because that will determine what we can see. And as I said before, when we do X-ray imaging, we predominantly, now currently in clinical practice, are looking at X-ray attenuation. So we have photons entering the body, so have photons entering the heart, and we measure how many come out, and we see how many have been absorbed. And from that, we then infer what the tissue properties would be. X-ray attenuation is done by atoms. So it's an attenuation of photons with the atoms, with the electrons, with scattering from the atoms. So X-ray imaging looks at atomic concentrations. That makes that for soft tissue, for discriminating soft tissue, and for example, discriminating blood from tissue will be very difficult. So we probably will need, as we later will see, we need contrast agents in order to do that. So that's intrinsic by the imaging modality. Then we have nuclear medicine. So what we do with nuclear medicine, for example, with SPECT imaging, what we do is we kind of inject radioactive material inside the bloodstream. And then we look at the dynamics of this, how this is being integrated and how this being taking part in metabolic processes and where it would be trapped within the body. And then we try to detect where these radioactive molecules went through by the fact when we look at SPECT, we have gamma emission. And so as you know, we have a gamma camera, we have a collimator, and this way we can see where photons are coming from, and then we can make a reconstruction of the distribution of these radioactive traces. Similarly, when we can use PET, where we have positron emission, which is based on the fact that we use now radioactive material that actually emits positrons, which very quickly would kind of annihilate with an electron, because we live in an electron world, so a positron cannot exist very, very long. It will meet an electron very soon. When they meet each other, they annihilate and they send out two gamma ray photons in opposite directions, and with a PET camera we can measure this. So again, we look at the distribution of a radioactive isotope within a certain molecule, because we really are tracing very specific molecules with this, and depending on what is the molecule that we make radioactive, we can look at different metabolic processes. When we do MRI imaging, what we now look at the dynamics of protons in magnetic environments. So what we look at is we are trying to look at how protons are distributed within the tissues and actually within molecules, because the molecular environment will determine how protons would react to a local magnetic environment and to, as we said last time, the fact that we can use radioactive radio wave energy in order to start to look at the dynamics and then or kind of change the kind of a stable position. We alter a stable position of the protons in the magnetic field by adding the radio frequency waves, and then we look at how this comes back to its original state. and what's happening in between. So we're looking at the dynamics of photons in a certain environment, and thus we can look at a molecular environment, as opposed to X-rays, which is looking at the atomic environment. With magnetic resonance, we look at a molecular environment, and specifically at the molecular environment with a lot of protons, and thus a lot of like water, because water contains most protons. And so we can look at soft tissues, and we can discriminate different types of soft tissues. And then lastly, we can also use ultrasound imaging. And the idea here is that we use ultrasound waves that we will transmit into the body, and we're going to look at how these are reflected by different structures. So we look at acoustic properties and acoustic reflection, specifically of boundaries of large organs, as well as within tissue, looking at scattering. So this is what we have at our proposal. And so as we said before, this actually gives very, very different types of information. So X-ray imaging, regular X-ray imaging gives projection information. We don't have any depth information, but it has the best spatial resolution. It cannot discriminate soft tissues, but it can look at, for example, hard tissues and calcium, but always at the best resolution that we have currently available. CT imaging looks again at the atomic concentrations. Now we do get spatial information because we can take a tomogram, but by the fact that it looks at atomic concentrations, it cannot discriminate different types of soft tissue, like, for example, boiled eggs and how much they are boiled. Magnetic resonance imaging can discriminate soft tissues, but, for example, cannot see the hard shell outside. So it's not good at calcium and bone imaging. And then with ultrasound, as we said before, you can see a lot of detail within the structure, but with additionally this kind of very typical speckle noise, as we say. And it also cannot pass through bone. It cannot pass through the eggshell. So we can only look in this case at hard-boiled tissues. So all of this will determine what we can use. So you will see that in cardiac imaging, if we need very, very spatial resolution, we unfortunately have to rely on X-ray imaging. If we want to look at soft tissue and without ionizing radiation, what we do is we look at magnetic resonance. If we want to look at bloodstream, for example, it might be worthwhile to look at computed tomography together with contrast agents. And ultrasonic imaging, of course, can also, because of the fact that it is the fastest modality that we have that can really do real-time imaging, can provide us information on motion of the heart while it's contracting. And so we can go over these one by one. So let's start with X-ray imaging. The regular X-ray thorax imaging, as we are used to, is still used in cardiology because it gives us a quick overview of what the heart will look like. So this is not used in regular diagnostics of the heart, but for example, in the intensive care unit, if we need to have a quick view of the heart, and very often also on, for example, catheters that are within the chest or within the heart, then we use this kind of overall view. And so you see the rib cage, of course, and you see the shadow of the heart. And when you know the anatomy, you can see that different parts of these shadows actually correspond to different parts of the heart. But what is much more important with projection X-ray imaging is that we actually use it for heart catheterization. And this is looking for the vasculature, and especially looking for the coronary vasculature, because as I said, like the coronary arteries, they're actually relatively small, because when we look at them, coronary arteries, it would be like a few millimeters, say about 3-4 millimeters. That would be the diameter of the origin of the coronary arteries in an adult. But very quickly after splitting, it actually goes sub-millimeter. So what we will see is that the interesting arteries are in the order of size of 1 millimeter, 0.5 millimeter in diameter. And these are clinically relevant. And if I come back to what I said before, so the resolution of MRI is roughly 1 millimeter. That would be the spatial resolution. So you will see that MRI is not great at visualizing this. And MRI is also slow. You need to do these pulse sequences, so it's not very fast. CT imaging, again, is about roughly 0.5 millimeter. So that's like on the edge of what we can do. And we will see that especially the proximal part, so the main part of these arteries, we can actually image with CT. But still, to get the biggest resolution, to go really in the order of tens of millimeters, then we need to go to projection X-ray imaging. And then again, because X-ray imaging is not able to discriminate blood from tissue, what we need to do is we need to use contrast agents. And we actually want to even to do selective imaging with contrast agents, because if you inject contrast agents in a vein from the outside, what happens is your whole circulation is filling with contrast and you don't see specifically the coronary arteries. So what we want is we really want to be able to inject contrast directly and only in the coronary arteries. And the way we do that is actually by using a very small plastic tube, so a catheter, which is mostly brought in through the femoral artery. So in the groin of the patient, we make a little cut in the femoral artery, and then we advance a catheter all through the aorta, going through the kind of arch of the aorta, and then coming back into just above the aortic valve. And then we can actually even selectively enter this catheter in the beginning, what we call the ostium of a coronary artery, and immediately inject contrast agent there. And then we can do imaging directly with the fluoroscopy, as we have been saying. So we have an X-ray source and we have a detector, and we can actually do real-time imaging there. And here are some examples. This is an example where actually we have a catheter, which is, so it's coming from below. So the catheter comes here from below, is going through the aorta. On top here goes through the aortic arch, bends, comes down. And in this case, the catheter has been brought inside the left ventricle. You see that this catheter is rounded here. It's what we call a pigtail, so that the edge is, of course, not sharp, so that we don't damage anything within the ventricle. And if we then inject contrast agent, what you will see is that you can actually opacify the inner side. You can opacify the blood. And you nicely see here the size of the ventricle. You see the contraction of the ventricle. And then you see the contrast going into the aorta. And you start to see here already a little bit. If you look well here, you see a little bit small vessels coming up here. So these are actually the coronary arteries. And here's an example of a very sick heart as compared to here a normal heart. So you see this heart is much larger, so it's dilated. You see the scaling is the same. So you see the spine has the same size, but the heart is much, much larger, or at least the inside of the left ventricle is much larger. And also what you see is, while here, for example, there is like a motion of the inner wall, which is the same everywhere. So we really have a homogeneous contraction of everything towards the center of the ventricle. What you see here is, for example, there's parts of this heart which are totally not contracting. You see this wall, actually most of this heart is totally stationary, and it's only this upper part which is a little bit contracting. So this is a very, very, very sick heart. And so using this, we can actually quantify size and contraction of the heart. Now, currently, this is not being used anymore, or not much anymore in clinical practice, because of course we need X-ray imaging and we need a lot of contrast in order to do this, and it is a projection. And keep in mind that contrast is also, contrast is not totally innocent. So this is kind of iodine contrast. And actually most of the contrast are what we call nephrotoxic. That means that they're toxic for the kidneys. And especially when we look at cardiac patients, very often they might have kidney problems also, especially in the advanced stages. So we want to avoid to need to put a lot of contrast agents. So this type of visualization of the inner side and the size of the cavity has now been almost fully taken over by ultrasound imaging or magnetic resonance imaging. So, but theoretically you can do it. And in some places it's still being done, namely when there's reimbursement. So when doctors are paid to do it, unfortunately, they still sometimes do it, while clinically not always that relevant. But what is relevant, and that's why this is being used, is, as I said before, is to visualize the coronary arteries. So here you see an injection where the catheter, here you see the tip of the catheter, is actually inserted, in this case, in a normal right coronary artery. So we see that when we inject the contrast, you see that nicely this artery is filling. And what you nicely see is that the size, so the diameter of this artery is only gradually changing. So it's like tapered, and whenever you have like a bifurcation, then you will see that the diameter decreases, but it's smooth. So there's no narrowings. So it really goes from larger towards smaller in a very, very smooth fashion. This, on the other hand, is a patient that had atherosclerosis. And what you see now is that you start to see narrowing. So here, for example, when you look here in the middle of this vessel, what you see is that the vessel is clearly much narrower compared to normal. So this is clearly a localized coronary artery stenosis. And if this is more than 75 to 90%, then this becomes problematic. And you see actually that this patient has more lesions. You see that there's several places where you get kind of a narrowing and then a widening again. So you see here also a little bit more distal, you see that also. So this is a patient that has several lesions, from which probably this one is the most critical. So this is a patient that likely does not have any kind of exercise reserve anymore and is at high risk to develop an infarct. Now, this is an ejection then in what we say the left coronary artery. So you see the other artery, again, a normal left coronary artery. As I said before, it splits almost immediately in two. And you see, again, very, very smooth going. And what you see here is a patient that also has abnormalities. So you see even there at the bifurcation of the big vessels. So when we look here in the beginning, you see that there is some narrowing. There's a big narrowing. So there's a lot of places where you have narrowing in this one. And one thing which is also interesting where we look at this one, and so this one, what you see, it's really a tree. So it goes from large to small, and it really forms this kind of a tree-like structure. When we look at this patient, suddenly what you see is there seems to be this vessel here going outside, and it's like hanging nowhere. So this is a little bit weird. This is clearly not normal. And what this actually is that actually this is a patient which has a fully occluded right ventricle. And this patient is lucky enough where the left ventricle, where the left coronary artery is actually connected to the right coronary artery and can fill it with blood retrogradely. So this is what we say, this collateral circulation, which is extremely rare in patients, because I told you before, in most patients, one coronary artery is not connected to the other, and that means that if one occludes, the patient gets a big infarct. But so this patient was lucky because it has a fully occluded right coronary artery. You see there's no blood coming from the right side, but luckily still doesn't have a full infarct because of this connection. So this kind of things we can visualize this way. Maybe one thing which is also relevant is when you start looking here, you see this kind of dark structure which is actually moving. So it's not beating with the heart, so it's not connecting to the heart, but it's moving when we apparently are moving the tube. So what you see is this overall motion of the heart is actually the operator which has kind of chosen an as small as possible region of interest in order to limit the radiation, but then moves the whole tube during the imaging in order to cover everything. So you see that this is actually something which seems to be stuck to the body. So you see it moves actually at the same speed as the ribs. So this is actually, and because it's dark, it's kind of absorbing a lot of X-rays. So the material can be, as we said before, either bone, but it's even darker than the ribs. It could be contrast, but contrast like this is also extremely abnormal. So what it is it's likely a metal, because metal also absorbs a lot. And this is actually an ECG electrode, which is on the chest of the patient. And so this way, by reasoning, it's like, okay, what does it look like on X-ray imaging? What type of material would it be then? What's its shape? What are the dynamics? We can actually infer and try to detect what type of structure this is. So as I said before, the biggest problem is that we would have a coronary occlusion. And currently what we do is, in order to treat this, so in order to be able to open this as quickly as possible, so to not have an infarct. So what we say is that when a patient feels chest pain and really gets this kind of tight tension in the chest, together with a little bit of kind of pain in the left arm, what we will say is then, of course, call the ambulance immediately. And if we can get patient in the hospital within 1 or 2 hours after the onset of this kind of infarct, after the onset of pain, what we then do is we actually bring in a catheter inside the artery, and we then expand a stent, which is like a little metal mace. We try to expand the stent there so that this metal would kind of keep open. It pushes away the kind of stenosis and the lipids, and it kind of tries to keep open the vessel and thus can re-establish the blood flow. So this is what we call coronary artery stenting. And in order to do that, obviously, we also need imaging. So here you see the same patient that I showed before. So has this big narrowing here. Then during the treatment, so we use the imaging in order to do the treatment. So we put a catheter through this kind of bigger catheter. We put a wire. We put a balloon here. So you see the balloon is inflated inside the stent. And then after the stent is placed, you see here now that this vessel is actually reopened, and you see a much better flow going throughout this vessel. So you see here that this kind of fluoroscopy, X-ray fluoroscopy, is not only used to diagnose the patient, to find problems with the coronary artery, but also used to guide the treatment, and then of course make an evaluation of the effect of the treatment. So in order to be able to see where it worked. Now, using this kind of fluoroscopy, as I told you before, since this is a X-ray source and a detector, what we actually can do is just like in a CT scanner, we could also move this, obviously much slower as a CT scanner. And this way we get what's called rotational angiography. This is like a phantom which is being scanned. And then we can actually do 3D imaging if we have enough projections. To do this in coronary arteries is not that easy. To do this in the brain, it's being used much more. So this way, with traditional equipment, we can actually also get some kind of 3D information. But obviously, CT is the way forward in order to do that. Okay, I think we can do a break now. I don't know if there's any questions about what I've been saying before. Or otherwise, let's do a 10-minute break and then come back.